Hello everyone, I'm Luis Ortega from Early Intervention and PCR Online, and today I have the absolute privilege, and I'm highlighting this, of interviewing Professor Mike Gibson from Bain Institute and the Beth Israel Medical Center in Boston. Dr. Gibson is someone I have admired for a long time, followed his career since I was in medical school, so for me it's an absolute pleasure to have you here. For the PCR Online audience, we are discussing the results of the AEGIS-II trial that was presented by Dr. Gibson in the ACC 2024 in Atlanta, Georgia. Professor Gibson, welcome to PCR Online.
Thanks for having me. It's an honor to be on your show.
For the audience of PCR Online, we would like to ask you, which is the rationale of the AEGIS-II study, which of the hypotheses that you were testing, the methods of the study, and you can wrap the main and key findings of the study for us?
We did this study for the following reason. I think, Luis, you all know that higher HDL is associated with better outcomes. And that's very, very true in the setting of a heart attack. In a heart attack, the lower the efflux, the lower the cholesterol exit from the plaque, the worse the outcomes. So while a lot of therapies have raised the number, the HDL number, we instead sought to give a drug or a therapy, I should say, that improved the function of the HDL. And we did this by giving human ApoA-I collected from around the world. Now it's added with a little bit of phosphatidylcholine to make it stable, and that actually makes it a little better in terms of its efflux capacity. But the idea was this: if bad efflux is associated with bad outcomes in the setting of a heart attack, we're going to give you a replacement of human ApoA-I to improve that efflux and see if we can improve outcomes over the next 90 days to a year. So we enrolled 18,200 high-risk patients. They had to have multi-vessel disease, and they either had to have diabetes or be old or have a prior heart attack and risk factors. And we treated them with 4 infusions of this human ApoA-I, spaced 1 week apart, or placebo. And it was matching placebo, it was blinded. We then looked at the outcomes at 90 days. 180 days was the secondary endpoint, as was 1 year. Now, the press release said we did not see a benefit on the primary endpoint at 90 days. That's true. But we did see a trend towards a benefit at 180 days, a p of 0.07, and likewise out at 365 days. When you do a multiple event analysis, not time to first event, there we have a p-value of 0.04 early on at 180 days and 365 days. So yes, close, but no cigar on the primary endpoint. But when you do the multiple event analysis, we do see significance. Now, the endpoint had cardiovascular death, MI, and stroke. There was no benefit in stroke. It was a null result. But for cardiovascular death and MI, we did see significant improvements again at 180 days. And here's the real punchline of the whole study. When you look at people who had high LDL, an LDL above 100, there was a 30% reduction in events, whereas people with an LDL below 100, there was absolutely positively no difference. The lines were superimposable on the endpoint. So if you don't have garbage, you don't need garbage trucks. If your LDL is below 100, probably not going to help. But if you are hyperlipidemic at baseline, it does look like there's an improvement. Now, I want to point out that this is a subgroup. It is an exploratory analysis. But I will also say that the P of interaction for that was statistically significant, meaning the LDL did modulate the treatment effect. So we are excited by the results. People will say, well, the HDL hypothesis is dead. I think that's an overstatement. The 35 members of the executive committee have looked at this in detail. We think the hypothesis is actually probably supported. It looks like there is probably a role of HDL in stabilizing plaque and preventing at least coronary events, not stroke, but coronary events. So, you do an honest trial, do an honest experiment, get a honest answer. Don't blame HDL, blame me. I picked an earlier time point. We thought we'd see an early benefit. And we actually thought it'd be the other way around. We actually thought we would have an early benefit and then over time the benefit would erode. But when you think about it, and we also thought about it in this way, this was the competing theory which lost out, was that if you delipidate plaque, the benefit would not only remain, but maybe emerge more and more later due to a legacy effect. So by getting rid of all the cholesterol, that would be the gift that would keep giving over time. It looks like the second hypothesis was correct, and we picked the wrong endpoint. So there you have it. I think let the debate begin. I think the hypothesis is got a good blood pressure and pulse, but let's see what people think of the data. And I think there's plenty for further improvement there.
Thank you for these enlightened results. A lot to discuss, Unfortunately, this interview has to be short. I have two comments. First one that come to my mind just to highlight the audience that total events analysis are very important. We have a lot of discussions previously in interviews in social media about they probably have more or less the same hazard rate or it's the statistics that the conventional time to event analysis, but therefore money for the burden of the disease, the burden of the care of this disease, and economical reasons have a huge impact. It's very different. I am very surprised about the fact that there is no difference in a stroke. Actually, it made me think a little bit that probably then the study will be actually underpowered if we are only just assessing coronary events. And my third thought, Dr. Gibson, will be it's very tough to compete with the standard of care these days. No, so standard of care is after the dramatic use of high intensity statins, addition of PCSK9, you have a huge reduction of LDL, and we have found a lot of studies that actually have been borderline because the standard of care is very good. In terms of future for this therapy, which is the direction the steering committee, which is the direction that you think this therapy will go?
Let me say just a word or two about stroke. Stroke comes in so many flavors, right? I mean, large to medium vessel, thrombotic stroke is just one of the many types of stroke. You have hemorrhagic stroke, you have embolic stroke, you have small vessel disease stroke, and none of those are going to be impacted by what we did. So, I think it's tough to improve stroke. We included it because we needed more events, to be perfectly honest. Likewise, type 2 MI, we included because we needed more MIs, but there was nothing there on type 2. It was all in type 1 MI. And here's what's fascinating for interventional cardiologists. Stent thrombosis was reduced early on. I mean, the human ApoA-I does have some antiplatelet effects. Where do we go from here? Oh, and I would also say, Louise, the event reduction in the people with hyperlipidemia, I only included people in that analysis who were treated with statins. So they were treated, okay? 92% of the population were treated with lipid-lowering therapies. Where to go from here? We're still digesting all the information. I do think there's a way to get this right, and that would be to look at death in MI, exclude stroke in the future, only use type 1 MI, not type 2. I also think that we saw no real benefit in people who had complete revasc. It was the people who did not have complete revasc where we saw the benefit. So those are the kinds of ways we could work in the future to really kind of narrow down the population that has the greatest benefit.
Try to search the perfect target, no, the perfect person, he or she for this therapy. I have to make you a question. It's a little bit out of the type of interview that we are having now, but I'm just too curious, and I have to make it. You have been a pioneer in social media use for medical purposes, informing, fighting back fake news. So
Yeah.
you are well known by all of us, and you are kind of I would say gold standard for most of people that try to do this. Having you here make me think, if you can give an advice to all the colleagues that are devoting a substantial part of their time for trying to inform people in social media, inform colleagues, which will be your advices for them?
But, I think social media is so powerful and so important. It is a dual-edged sword. We do see a fair amount of misinformation out there, but all of us have got to do our job to combat that misinformation. And thank you for, working on that as well as many others. I do think in the past we had key opinion leaders. That's one way to look at the world, but now we have digital opinion leaders. They're two very different skill sets. The key opinion leaders often kind of run the trials and do all that. But the digital opinion leaders, they're synthesizing a lot of all that information that's out there. People have way too much information to pick from. They need people to help digest the information and kind of curate it for them. And that's why the digital opinion leaders are so important. Not all key opinion leaders are great communicators. A lot of great communicators are digital opinion leaders, and they both serve a role. So, find your niche. I think we need a lot of people to really get the job done. People want to hear a lot of different voices and points of view. Even if you're young, you can still be articulate. You can still be evidence-based. You can still offer very, very insightful comments on the data. So find your voice, use your voice, and, get involved.
Thank you, Dr. Gibson, for all you have done, for the research perspective, for teaching perspective, for communicating perspective and informing. It has been an absolute pleasure for me. I know that you like short interviews, so we have to come to an end, but having a complete pleasure to having you in PCR Online. We will be following the ApoA-I hypothesis, and we will following the subsequent analysis from AEGIS-II trial. Thank you for your time.
Thanks for having me.
For all the people in PCR Online, we will be doing a live covering ACC in Atlanta, Georgia. We'll have AEGIS-II, but we'll have also a lot of trials that will be coming, especially for interventional cardiology. So keep us in tune with us. Thank you for all of you. Goodbye.